All right, let's go ahead and get started, folks. I'm going to go ahead and hand it off to our webinar host, Carmen Vasquez.
Hi, good morning, everybody. Thank you for taking time to attend this session that is offered by both Prochant and Allegiance Group. I probably know the majority of you in attendance, as I've been in DME for quite some time as either a provider or in a consulting role. I currently am one of the 4 regional reimbursement directors at AeroCare. The next panel, we have 2 panelists with us this morning. First is Joey Graham, who is the EVP and General Manager at Prochant. And our second host is Bruce Gehring, who is the Senior Vice President in Business Development at Allegiance Group. I know this is a little bit of a shameless plug, but I can't help myself. I have known both Joey and Bruce in a personal and professional capacity for quite some time on every angle of this business, from being a partner on the operations side versus referring a lot of business to them. So I do consider this quite an honor to be able to host this webinar on their behalf.
Thanks so much, Carmen. I'll do a quick introduction of myself, and then Bruce, you introduce yourself. I'm Joey Graham. I'm the Executive Vice President, General Manager at Prochant. We're an outsourcing company working with providers all over the country, helping them solve their business challenges, especially on the insurance revenue cycle side. So helping with the full revenue cycle from intake all the way through back-end billing and collections. I've been in the industry for over 20 years now. I actually started right out of high school as a service technician at a provider down in Florida, and I worked my way up the chain of command over the next 10 years until I was able to actually go out and become a consultant working with Brightree, traveling the country, working with providers, helping them solve their business challenges. And then eventually that led me to my current role at Prochant. So very excited to be in front of you today. Definitely, I still have that provider mindset, and excited to talk about intake because it's such a critical piece of the puzzle. So Bruce, how about you tell us a little bit about yourself?
Fantastic, thanks, Joey. My name is Bruce Gehring. I'm Senior Vice President of Business Development here at the Allegiance Group, and I've been with the Allegiance Group since 2008. Our focus has been specifically on the patient pay part of the revenue cycle. So I've known, as Carmen mentioned, Carmen for a long time when she was with the software company. We worked with them as a partner, and I've worked with, Joey in a number of capacities throughout the years. And recently with Prochant, because we certainly recommend their services to people that are needing outsourced billing services. And the two of us have worked together on numerous accounts, helping provide that full revenue cycle requirement or service that you're looking for. So we've been able to kind of throughout the years understand how the industry has evolved and how we need to evolve with it, and can hopefully point out some best practices for you guys today on patient pay, billing, and collections, as well as the ins and outs of intake from a billing service standpoint with Joey's team. With that, I'll turn it back to Carmen.
Thank you so much, gentlemen. Again, all of you attendees, these are 2 outstanding companies that have great services that I can't always say it, but I have professionally used both of the services that they offer. Mm-hmm. Okay, so I think the first thing that we want to talk about is intake and eligibility. So my first question is, what best practices do you recommend for collecting the patient portion up front, as well as what it's like for the ongoing monthly rentals to drive those operating efficiencies and profitability? Yep. Bruce, would you like to answer that first?
Yeah, I sure would. You know, I think one of these things that we see over and over again is this is not taken for granted, but there is a huge opportunity here for providers to improve their patient pay recovery if they take some more time at the front end at intake and establish some, credit policies and procedures that is part of your intake process. And by that, what I mean, I think, providers have a responsibility to, create the right expectation with the patient, and making it standard procedure to capture as much patient demographic information and getting a credit card on file for those deductibles and reoccurring, copays that are going to occur is critical. And really what you're doing is taking the surprise out of the patient responsibility. And that's essential for good customer service. If they know what to expect, then it's not going to be a problem down the road. And if you can go ahead and explain it in such a way that they understand that responsibility, and it's just a normal process to have that credit card on file for reoccurring rental or resupply, then you're going to forego a bunch of pain in the long run trying to chase a bunch of patient pay bills down the road. And, it's not just, everybody does a pretty good job of getting like the first month's rental up front. But the fact that you go ahead and establish that reoccurring charge for an auto payment is really the key. And I'll tell you, we have clients that have made this such a focus that they're seeing their patient pay recovery leap to 80–90% when they can go ahead and have this process in place. Just think about it in your own terms. When is the last time you went in to see the doctor and did not pay your copay before you sat down in their office for that visit? And that's just critical. We've got to make that standard operating procedure, and that expectation has to be there with the patient when they come in. And there's some referral education that has to come into this too, because your referral partner needs to be able to explain that to the patient when they're visiting with them as well before they even come to you. But that's a very high level, but I think those are the critical pieces. Carmen, you can probably add to that.
I would like to add to that. I've got a couple notes, but I'd like, Joey, is there anything you'd like to add to that before I can give you some real world examples, just operationally from running a $150 million region? So everybody has copays. Joey, anything that you would like to add around that?
Absolutely. And I want to kind of start out by giving a little context to the group on the call. We're in a very short call. Unfortunately, we're going to be about 30 minutes here together. So obviously we won't be able to share too much, but what we're hoping to do is give you guys some really good snippets during this 30 minutes. Hopefully you're munching on some lunch and you get some good stuff out of this, and then you're able to kind of move on with your day. But when we talk about intake and we talk about the ins and outs of intake, what we're really talking about is what's on the screen right now. So this is just to kind of have you guys, help you visualize this process, maybe help you apply this to your business. But we're really talking about this full set of steps that happens with every new patient that comes in, right? You've got that fax that comes in, or that order that comes in through the fax wrangling step, or maybe you have the patients walking into your retail store or calling in with these orders, physicians calling in orders, but all that's kind of funneling into that intake and eligibility team. And that's really what we're focused on in this segment of the talk, is that intake and eligibility team. So what I want to start is kind of clarify, there's the intake process. The intake process is what you see on the screen. That's everything that happens before you go fill the order. You notice that order fulfillment kind of grayed out on the right. So this is all pre-fulfillment. Everything you do before you give that patient their piece of equipment or ship it or provide the medicine for the patient. And then when you're going through that intake process, you get to that step, that intake and eligibility step. And so that's really where we're focused on right now. And when it comes to intake and eligibility, some really important things I would say are, first, the purpose of eligibility in your business is to determine financial responsibility. In other words, when you are done with eligibility, some people think that eligibility is really just about finding out whether or not the insurance is active. And yeah, that's one step in the eligibility process, but the purpose of eligibility is to determine financial responsibility, such that by the end of eligibility, you're able to tell that how much I'm going to get paid and who's going to be paying me in what order, right? So I have full visibility to that as I'm exiting the eligibility process. In order to get that level of knowledge, sometimes we may over-rely on electronic eligibility, because very often electronic eligibility is simply that yes or no, do they have the coverage? It's not answering, am I an in-network provider for this specific plan? Are there any special requirements for this specific plan? If you just have United Healthcare as an example, they probably have 10,000 plans, if not more. And every one of those plans is tied to different networks and different nuances. And so you go run a UHC eligibility, yeah, you're going to get that they have it, and you might see the name of the plan, but you're not going to know much more beyond that. Are you, so there's sometimes, especially on an initial order, before you bill out month one on something, you want to have that phone conversation sometimes with certain payers to make sure you get true eligibility information. Now, if it's Medicare Part B, there's no need to call Medicare Part B, right? Obviously, everybody with Medicare Part B has the exact same benefits. So we know those benefits, we understand how that works. We don't need to call. If they have Part B and it comes up active, then that's good. We're good to go. But if it's UHC, I mean, you can run electronic eligibility, but unless you have a really good understanding of the plans and your network participation with regard to those plans, you still might get into some sticky stuff down the line. You also want to program into your billing system things like your coverage limits. You want to kind of dummy proof your billing system. So the thing is, we rely on our intake people to be like the end all be all knowledge workers who understand every requirement for every payer, right? And that's just not reasonable. And also we're asking them to do things like make sure they don't over dispense, right? Because they may not know that the patient came in last week and got a mask, but now they're up for resupply and mask, right? And so, make sure you program those coverage limits. So the system will say, hey, we just gave them a mask. Don't give them another one. Also, checking things like same and similar up front is so important to prevent denials down the road. And even getting things like the discharge date up front, especially on like a patient is a hospital discharge, they're expected to discharge tomorrow, get that discharge date, because, so that's also very important information to have. Especially as you get down the line and you want to prevent denial from happening in the first place. And I just want to echo what Bruce said. I mean, the number one thing that providers are doing right now in terms of the patient pay side is getting those credit cards on file up front. You don't take the order without getting a credit card on file. I've even seen providers get multiple credit cards on file just in case one of them declines. But anyways, getting that credit card up front and kind of setting that tone up front with the patient that this is not free. This equipment is not free. This service is not free. This medication is not free. Just like any other healthcare experience they have, there's going to be copays, there's going to be deductibles, and there will very likely be a shared financial responsibility. So I'll give it back to you, Carmen.
Thank you, gentlemen. I think that both of you had some great points, and I just want to add a few thought-provoking ideas out there for all of our attendees. First, just piggybacking what Bruce said in that patient pay arena. Deductibles, as you know, they're not getting smaller, they're getting bigger. I too have been in this industry 20 plus years, and I remember when the Medicare Part B deductible was $100, and now it's $203. So deductibles are not getting any smaller, and the only thing getting smaller is reimbursement and the profit margins that we have to work with. None of us anymore can stay afloat and be profitable without that patient portion. So a business practice that we follow is we require on our operational side a credit card to be on file unless there's approval of one of the regional managers, because we take that private pay piece so serious. The next piece that I add around that is from a customer service perspective and how we represent ourselves as companies and sharing in that continuum of care with patients is accurate copay estimates. We can never guarantee benefits, but it's not a shock for us if we're going to do a CPAP setup for us, we do a lot of Cigna. Their deductibles are pretty high at the beginning of the year, and we do have some patients that opt out not to use their insurance for that reason. So having visibility and transparency with your patients is key. If you have a patient that can't afford their copay month one, unless they win the lottery, they're not going to have it for the future life cycle of being your patient. So that's again why we require that credit card on file or an approval from one of our regional managers so that we are securing that payment, or at least we know how we're going to start that relationship with the patient. As far as eligibility checks at the time of intake, I'm a huge component and fan of this. I did want to add that there is a giant difference, to Joey's point, of going direct with a payer versus any third-party clearinghouse. They give us the basic information. That doesn't always mean that we're still covered. Joey used the example of United Healthcare. I am a United Healthcare provider in the whole state of Colorado, but there are certain Medicare Complete plans that we don't take because Apria has the exclusive contract. How do I currently get around that? We use cheat sheets by payers for our top 10 payers so that we can at least recognize groups. That isn't a foolproof system, needless to say, but it probably runs interference on about 80% of the payers that we see at the time of intake. And lastly, and I do feel real strongly about this after the years of being on the software side and implementing software, you will get out of your platform what you put into it. Junk in, junk out. Taking the time to build it what only increases your ability to be more successful. Know your system features. If you are a current Brightree user, for example, you can set quantity limits on your PARs. That's giant for me in the state of Colorado because our Medicaid program pays for things that Medicare doesn't, like supplies on a invasive vent patient. So us tying that in not to a date span on a PAR versus the quantity is big. All of these software vendors compete for your business, and they have a lot of the same features. They also take all of the crabbiness, feedback, frustration that we have with them, and they put out new features. And then we do tend to be bad students on the operational side because we get very busy and we don't always keep up with what the new features are that they offered. So as far as that intake piece and making that seamless, I think those are just some good points to follow up with. We also know if you've been doing DME 20 plus years, we are actually asking our intake people now to almost be infallible. And they are processing more orders than they've ever done with a shorter time period to turn it around because we don't have the golden commode era is over and we have to do more with less. So anybody on a reimbursement level can tell you, we live with the good and bad of what happens on the front end of the company. I also encourage any of you to have a really strong relationship with the front of the house and the back of the house. Historically, operations and RCM tend to get a little scrappy, and they really shouldn't be. For my region here, we constantly preach their success is my success and vice versa. We're all in this together, and I spend a lot of time in the field with my operational teams training because the more information they have and the better that I arm them at intake only benefits them to be able to process cleaner, more efficiently, and increase that number of orders per customer service rep.
Those were great points.
Okay.
Yeah.
Thank you. I'm going to try to move this along because I know we've got a lot to cover here. The next thing I'd like to talk about is documentation. Joey, I'm going to ask you this question. What is the best practice to receive, track, and respond to referrals?
Sure, that's a great question. And really, the answer to that question, you have to kind of jump back a couple steps in the workflow to that first one that you saw on the slide a couple of slides ago with the fax wrangling. So that in other words, that's your inbound channel into this workflow. And basically, when you've got that fax wrangling process, or you can kind of think about them as almost like the air traffic controller for new orders that are coming into your company, they're going to be handling all those inbound e-faxes, emails, other referral methods, including e-referrals. So this team is responsible for routing and creating that workflow for the intake and eligibility team that we just talked about. And one of the most important points there is that every referral is entered in the billing system or the workflow system immediately. We keep running across provider after provider is they'll have a process that lives on paper or that lives in email or lives somewhere else until they get to some point. And then at some point in the process, they go, okay, now I'm going to put an order in the billing system. And it's a big no-no to us. You know, we want every single new order to come in and get its own record immediately, even if it's just a skeleton record, meaning patient's first name, last name, date of birth, hit save, right? Don't worry about all the other stuff. Create a new order, tie it to that patient, go ahead and attach your documents to that order, and then queue it up for the intake and eligibility person. And when you do that, make sure that you put in the sales rep and the referral source. That's really important information because one of the things that you need to do is get that sales rep notified immediately that they've got a new order. This is very big for not only the sales team to get excited about there being a new order, they're going out there doing all these calls and they're getting some good results, but also it kind of gets them on notice that there's a new order and their help may be needed, potentially if there's going to be an issue or something like that where it's going to have to be escalated to the physician. Once you've got that stuff logged, then there's a lot in terms of tracking you can do with that reporting. I definitely like to see weekly reports for the sales reps for their, referrals that came in, to kind of get that trended week over week, so you can kind of see if you have a doctor dropping off or you've got a new doctor coming in, giving you orders that hasn't before. Things like that are really critical in terms of that tracking and reporting piece. And you asked about automation opportunities and any kind of automation there. And I think there's a lot of opportunities for automation as we go through this, and starting with the data entry. Carmen, you and I have talked about the importance of e-referrals and e-prescribing. And when you have a system like that in place, it gives you the ability to automate things like the data entry of the patient into your billing system, where you click a button, patient records created with everything that came over on the referral. Even if it's not a native integration, like there exists with some of our billing systems, they might have a native integration with an e-prescribe platform. There's other technologies out there that we have to kind of keep in mind. And the one that I would kind of put on everyone's radar is called RPA, or robotic process automation. RPA, you just search it and start to search what it's capable of doing. You find that there are incredible opportunities throughout this workflow to introduce automated steps to take work off of people, even going to other referral services that maybe aren't with a native integration to your billing system, and still automating that data entry, automating things like an electronic eligibility, automating the routing of the order based on payer and product. The order gets routed to this group. Especially as the larger providers, there's a lot of that kind of logic built into their systems where work gets automatically routed to the right people based on parameters in the data. Nobody had to go in there and move the whip state or change who it was assigned to. The system did that itself. And the last thing I would say you could automate is those acknowledgments, not only the acknowledgement to the sales rep that they have an order, but you can automate the acknowledgement to the referral. Hey, thanks for the order, we're processing it now, things like that. So that's what I would kind of say in terms of documentation.
Hey, Joey.
I think, Joey, those are all great points.
Yeah. And I think Carmen already mentioned this and Joey just spoke about it, but it is understanding your software, its capabilities, and the more you can integrate with that and automate, the better off you're going to be, more effective and more efficient. And that's just really critical to all of our needs at this point, because you have to do more with less.
So the only thing, attendees, that I would like to add that Joey touched on, but really drive the point home with some live example, is e-prescribe, e-prescribe, e-prescribe. That is going to be a game changer in how fast you can process information. And I strive, of course it doesn't happen, but it's something that I track, to have touchless, and I shouldn't say touchless, contactless referrals that come in. Because every single time that a rep has to call back a referral source, it slows down delivery, and all it does is anger the referral source. So one good example I can give you that just came up yesterday. I got an order, I have a CSR and a sales rep asking me to make an exception because the testing for the Medicare oxygen patient said the patient's O2 sats today were 88%. At rest, exertion, what was that going to be like? So that, to me, if I had had e-prescribe where that's all built in, it would force them to make that decision, and I wouldn't have even been having that conversation. I also remind people in e-prescribe, doctors can sign that stuff from the golf course. You also are automating their life. Technology has to be part of your new world in 2021 as a DME provider. Okay, next question I have it goes around prior authorization and pricing transparency. And I said earlier how important I think that transparency to patients are, just for the perspective of what they're up against. So Joey, I'll ask you, what are some best practices for managing authorizations for transparency. And I would specifically the difference of that initial auth and that re-auth if necessary.
Absolutely. The first thing you have to do is make sure you set up your billing system with your prior auth requirements. That it sounds simpler than it is in some cases, because Carmen, I'm sure you've come across this where you mentioned United Healthcare before. There might even be policies that require an authorization, like a United Healthcare that requires an auth, United Healthcare that doesn't require an auth. And so when it comes to setting up your payers in your system, sometimes, unfortunately, you might have to set up a payer multiple times to account for this and be able to really set it up properly. You know, Blue Cross would be another good example. I've seen many cases where there will be a par versus a non-par instance of an insurance. And the reason that it gets set up like that is to be able to very quickly have the right rules in place whenever you're processing a new order. So figuring out really, you know, during the eligibility step really is when you should know for sure, does this item require an authorization? And if so, you know, that should move on to the auth team, or that might be the same person working that. But it's important that the billing system enforces it, right? That it's not something you just have to remember, but there's a possibility that we're going to confirm this order and it's going to transmit without an authorization. Right? Maybe it's going to go on hold and that's okay. Or maybe we can even put some front end edits so that we won't even get to the dispensing step unless we get that prior auth in place, or at least request it and get one tied to the order. All that stuff is possible with our billing systems. And of course, you know, you want to make sure you set up what I call a knowledge base, or like a dictionary of for your employees to reference, just kind of help them understand this payer, this product is an authorization required. It's kind of like a crosswalk. A lot of providers have things like that. It could be stored in like SharePoint, it could be on your intranet site, it could be an Excel file that you share, but just some sort of reference point that your employees can go to and really quickly see, based on the payer and the product, is an authorization required. You want to communicate with the patients that a prior auth is pending. And if you have to dispense before you get an auth, which we definitely don't recommend, if at all possible, you want to hold dispensing your product until you've got your prior auth closed and logged. But if not, then you want to make sure you have that a process in place to handle that, where when you do provide the product to the patient, you let them know that their prior auth is pending and there's a possibility it will be denied. In the case it gets denied, they may owe financial responsibility. And that might be a good segue over to Bruce, you know. So let's say that happens. Let's say we get to the point where, you know, we thought it was good to go. Now we're going to have an authorization and it's not going to come through. And that goes to that pricing transparency, right?
Yep. And, you know, it's so critical that you have your terms set up when you're creating those payment plans or auto payments according to those authorizations, because, you know, all of a sudden the authorization come through and then guess what? The whole balance is dropping to the patient. You just charge their credit card $800 or whatever it is, and they didn't expect it. You know, that's huge.
Absolutely.
So I would add two things, I think, behind Joey and Bruce in this arena. The first is that as far as that initial authorization, there are payers out there that do not backdate. Blue Cross Blue Shield AIM for me does not backdate a par. So if I set it up today and they don't give me an auth for 2 days, I'm either having to adjust my rental date or eat the first month, which none of us want to do. The second piece around the transparency of setting up equipment with pending authorizations is, to Bruce's point, still securing payment if that doesn't come to fruition. We do a lot of pediatrics in my region, and as you guys know, children cannot be on BiPAPs because of their age, so we move them into the non-invasive world on the non-invasive vent. United Healthcare religiously denies those, and we end up in a peer-to-peer. We also have to stop assuming that people don't have money for their medical expenses. People have the money. I've watched people turn down orders, and I've had patients say, can I just pay for it privately? We're so used to saying no to the hard, cold cash that we need to get better at that. So the transparency around what will happen if we don't get that authorization and that family still making the decision to set that up while securing payment is key. Okay, my last question, because I know that we're kind of pressed for time, is scheduling and dispatch. What software providers are you two gentlemen aware of that are being used currently in the field for this function, for scheduling and dispatch?
Sure, I can start on that one if you want, Bruce. I've seen many different systems in place, working in the industry for several years now. Everything from, Outlook Calendar or Google Calendar, which, honestly is not a bad option. If that's what you need to use, then use it, because they've got a really strong calendaring tool there that you can leverage. But also, if you have a billing system that has an inbuilt, calendaring feature, certainly that's going to be preferred, right? Because then everything's going to be tied together. And all the major billing systems do have some sort of calendaring feature, but they also have is a mobile delivery. And a lot of times those two are kind of tied together. The scheduling and the mobile delivery, it's kind of one module within the billing system. And if you haven't explored mobile delivery yet, that's something you need to explore like right away. I have yet to come across a provider who implemented mobile delivery and then regretted it. I know it's a bit of an upfront expense to get the equipment sometimes, to maybe purchase the licenses and do the setup. But on the back end, Carmen, I'm sure you would agree as well, because you guys have an incredible mobile delivery system that you use. It's just huge. The benefits that come from mobile delivery it's innumerable. Not only do you get the paperwork back immediately, not only does not one more ticket get stuck in someone's glove box and forgotten, or somebody spills their cup of soda on it, or puts coffee stains, or just so much stuff happens with these pieces of paper. When you get to that mobile and they just sign on the screen and they get an emailed copy and it goes right into your billing system, right into the patient's file, signed ticket. I mean, that's the dream, right? And then, there will be providers who use some third-party specialty applications. I mean, if you go onto Google and just search, patient scheduling, just do that. Go to patient scheduling software and search, and there's a whole bunch of them out there. You could find just a single solution, as a software you like, that has all the scheduling features you want. What patients or what providers like about that is sometimes those softwares will have features that the billing system doesn't, like automated reminders to the patient, reminding them about their appointment, and even the ability for the patient to kind of self-service their appointment and reschedule and pick a new time and all that stuff. And one more thing I've seen is the use of other healthcare EMR systems, because sometimes they may have a more strong scheduling platform. When you look at something like Advanced MD or Athena or even Epic and Cerner, if you have access to software like that, they sometimes have a more advanced scheduling feature that you might leverage.
I think all of those things, Joey, are amazing. And the only 2 points that I would add around that is, again, that feature of technology. Obviously, I don't work at your companies, but if I ever had any influence, it would be stop using Excel spreadsheets to track the amount of business that you do that opens you up to a ton of human error. One of my favorite features that we do as a company is we are paperless. And that makes a giant difference. And it takes a while if you've done DME like Joey and I and Bruce for 20 plus years, that we used to need 80 pieces of paper to set up a walker. It's more efficient. It's clean. I have an electronic signature. We confirm within 48 hours of delivery here. And we auto confirm a lot of things, but the things that we put an extra set of eyes on, our policy is within 48 hours. And the quicker that I confirm it, the quicker I get paid for it too. So again, technology, we got to stop being afraid of technology. Every platform any of you are using has a mobile device delivery system of some sort. And then working towards the automation piece of being paperless. Yeah. Bruce, I have a question for you. When is the correct time to collect patient payments?
That's easy. Anytime you can. But I tell you what, you hit on several points, because having access to the internet is critical. And if you're delivering product and you haven't got payment, you don't want, if you have a mobile delivery application, stuff like that, and you still haven't got it connected to a way to be able to take a payment online, you need to, because your leverage goes out the window with that customer if you deliver the product without having the payment being captured or the method of payment captured for a reoccurring rental or whatever. You've got to do that, because that's a huge opportunity for you to establish that payment hasn't already been done so. So, I mean, simple question. I mean, you've got to have a means to be able to take a payment on the spot, wherever that is. And typically that means you have to have a connection, wireless email or wireless connection, whatever, to be able to go ahead and establish a patient. You can even set up a patient portal or payment portal for them to be able to log in, later, to be able to follow their bill, self-manage, and all those types of things. There are so many advantages, but getting people connected digitally is critical, because there is tons of statistics out there now that if you're connected to your patient digitally, they're going to be a better payer. And that's just across the board. And I think all of us can, reiterate that. But that's my last point.
So the only thing that I would add behind that operationally is I get asked a lot, well, that sounds amazing, Carmen, but I don't want to cut a bunch of refund checks when I'm estimating copays. Awesome, me neither. We actually get the credit card up front at delivery. We then turn around and run the credit card when the patient portion is created, but we email our patients 2 weeks prior to running their credit card. So we don't want to issue a lot of refunds either, but that. Contact me privately if you want me to shoot down all the reasons not to collect your copays up front, or at least secure that credit card on file, because I will have a reason every single time of why that's critical. When I look at the AR as a whole, but obviously more for my region, my DSO sits in the 20s when I take out private pay. The AR is actually still there. It doesn't make it less real because it's there. And it's a stifling number for people that don't secure that payment up front. And a lot of that for us is older acquisitions and whatnot, but that's a pretty critical piece there. Technology and getting paid for the services that you do. All of us have had referral sources call because they're angry that we billed their patient. To Bruce's point earlier, I have yet to be to the doctor where they don't even let me in until I pay my copay. We can't be afraid to ask for the money that is due to us.
Right. Agreed. And I think there's a couple of questions in the queue. Is that right?
Well, let's see.
There are. I know we're out of time, guys, and I appreciate everyone for jumping on with us. If we stay on just another minute or two, maybe we can knock through these questions. And there was one that came in, Carmen. I was curious to get your thought. And it says, in terms of collecting payment from patients up front, what if that patient has Medicare and Medicaid? Can you kind of give some ideas on that dual eligible population, and are those maybe the exception, or how do you kind of think about those?
So I have several thoughts around that. And the first is be really familiar with your state Medicaid program, because we don't all have the same rules. In the state of Colorado, we have something called Title 19 coverage. That's not your standard dual enrolled patient, and they will pay in the primary position with an authorization and then denial from the primary payer. In that situation, I'm not even allowed to obtain an ABN because Medicaid is in the secondary position. If my patient has, when I said we do every now and then set patients up without a credit card, that is usually your Medicare and Medicaid patients. We do not stop intake or delivery on active Medicare and Medicaid patients that are dual enrolled for a copay. Now, got to be on top of when coverage denies, or if any of you are from Missouri, your patients have to meet a spend down. That might be a little bit different of a situation. But as a whole, those patients are probably always going to have the coverage.
Yeah. Very good. Somebody asked, what is mobile delivery? And, I think I can take that one. When we say mobile delivery, the traditional way that we do delivery in HME and in pharmacy is we'll print out a ticket, or we'll print out some kind of receipt, and we're going to ask the patient to sign on that. And then, that's going to end up going to to be scanned in. Hopefully we're not doing paper files. Let's not even go down that road. But we're going to scan that in and then put it in the electronic medical record but it lives on paper. And so mobile delivery is simply taking that paper and putting it digital. And there's many flavors of it, right? I mean, there are fully integrated systems with each of the major billing systems. So just whatever billing system you're on, if you contact them and ask about their mobile delivery solution, I'm sure they'll have a ton of information for you about it, where you're going to get that ticket on a phone or an iPad, and the patient's going to be able to sign right there on the screen. But also, I just want to mention, if that's maybe too expensive or you want to do something different, people will use things like DocuSign. Have you ever heard of DocuSign, or another just e-signature platform, right? Where you take that ticket, you send it into DocuSign or something like that, and then you go ahead and have the patient sign using that application, but still on a mobile device, and still no paper. You still get that signed ticket right away back. So that's what I would say for mobile delivery. Does anybody want to add anything to that?
I think that there's a ton of features that are out there, and there is something in all of your platforms called an API. If you're a premise-based system, you probably have to buy their tool to write to it. If you're on a web-based, you're probably also going to have to ask permission to access that API. Back in my consulting days, I had several clients that wrote their own through that API to connect into different parts of their system. I would also encourage you guys to explore the options of the integration in between your platform and a third-party software. For me, that mobile delivery is more than just capturing the patient's electronic signature. It also sends out notification to a patient when we have a delivery tech or respiratory therapist on the way, along with a picture. Why do we do that? Because we service an elderly population. All of us are in healthcare with sick and scared people, and we do our best to ease the minds of people that are answering the doors to a complete stranger. So there are mobile delivery devices that go just beyond that signature.
And here's one more, Carmen, that I'm curious to get your thought. We got a question that says, what type of script or wording does your intake team use when they're asking that the new customer for a credit card, to explain why that's needed at, upfront during intake, if the patient kind of pushes back?
And we do get some pushback. So again, building that platform is key. What we do to enhance that is build the system around intake to have accurate copays based on the payment percent that's put in. 80, 90, obviously 100% doesn't have a copay. The script that we use goes something like, we verified your benefits, you have X amount of deductible that hasn't been met. Once that's been met, you have a X% copay. How would you like to secure your copay? And then if we do get some pushback sometimes from people that say, yeah, bill me, I don't want to give my credit card out. Our response to that is, I only have so many dollars that I get to work with operationally for the reimbursement that's out there. Patients obviously don't care. They think that we're all millionaires regardless, not looking at the high labor that it costs to run our businesses. So my response to that is always that I only have so many dollars for that patient experience, and I want to put my dollars towards technology and better therapists and be able to physically service and see our patients more often, now obviously in the telehealth world as well. And the biggest way that I can make that experience better is to remove the administrative cost of mailing out 10,000 patient statements a month. Right. It's amazing how many grandparents now have iPhones, and they're really slick on those, and they know how to use that technology. So that's our response to that, is every now and then we might make an exception, but it's very few and far between that we don't. And we do say it's a place where we cut out administrative costs because of technology and the place that we are now as far as internet, email, telephones.
Yeah. And, Carmen, I'll just add to that, because I think one of the things that we hear a lot of times is, what is the answer that you need? Well, I think this is a great place to engage your team, because you can also create those answers based on the frequently asked questions that come up. And so if you can go ahead and have a scripted answer for those typical scenarios, and then everybody trains on that, then it gets back to the customer service. Everybody's doing the same thing in the same way across the board, so it's handled consistently.
Yep, that's right.
Joey, do we have any additional questions?
There's just one more, and it says, we run into issues where the delivery techs still do not complete documents like they should with the mobile delivery device. So for instance, they're not checking all the boxes they should be, they're not completing all the empty fields. And so they're still getting probably paperwork back that's missing stuff, and then that you have to go out and get it signed again. You know, I bet you have some thoughts on this, Carmen. I would say when I hear about a problem like this, my mind first goes to, is this a system issue or a training issue?
Right.
If this is a system issue, then there's probably some setup that I can do where I can make certain things required, where I can say, you know, system, do not allow a document to be signed unless somebody has acknowledged each one of these boxes. You know what I mean? Like that's, for instance, I mentioned DocuSign earlier. That's just some built-in, you know, functionality there. But the other systems I would say have something similar. So you want to kind of first go down that path, and can I kind of systemize this and make it so that they can't possibly get through without answering certain questions. But if it's, you know, there might be certain things that are situational, and there's no way for you to make a box situationally required. You know, like if it has an ABN, then this is required, but if it doesn't have an ABN, then this other one. And so sometimes that is just very difficult to systemize. And if you can't, then it becomes a training issue, right? And so from there, then you have to start looking at some quality assurance checks and some points where you're going to have to get downstream feedback, maybe from the confirmation team. Maybe you can set up some reporting that will call these out quickly, and they can be addressed proactively before they make it to confirmation and become errors. And then sort of figuring out, how do we retrain the technician? You know, so that's sort of where I would go with that question. Any other thoughts?
So I have a few thoughts on that. Having a software background, things do not randomly happen. If there are system issues, they happen to everybody unless it's specific to that handheld device that they're using. I've had people say they accidentally wiped out their C drive. No, you didn't. And it didn't just, your software system didn't wipe that out either. So things that randomly happen are usually a user issue. Things that globally happen are usually a software setup issue. So my advice there is to make sure that you've provided adequate training to your employees. I'm big on training. I'm big on arming my teams with tools. And I'm really big on quality assurance of training. I see a lot of managers make the mistake where they train once and they never talk about it again. You're going to get into your teams what you're going to get out of them what you put into them. So I would make, if it were me and I had an employee that had those issues, I would be saying, have I done all the training I can? And if I've done all the training, then I have a personnel issue. Unless you're going to make it optional. When I first rolled out mobile delivery, I had an RT that every single order he did came back with paper because his patients just couldn't figure out technology. Every other person around him was just fine, but it was just him. It finally came down to he didn't want to use the mobile device, and it had never been out of the box. So sometimes we just have to help people, especially the veterans in this industry that remember when we used to get out typewriters to type out claim forms, really showing my age now, how far we've come, and that technology isn't as scary as it sounds.
Absolutely. Well, I apologize, everyone. I know we went a little bit over, but this is such an important topic, intake, and there was so much interest. I mean, we have so many people on this webinar, and we're really appreciative of everyone for joining. This is certainly a hot topic in the industry right now today. So if you have any other questions or thoughts, please don't hesitate to reach out to any of us. We're happy to work with you on those. So thank you guys so much for joining us today. And thank you to Bruce and Carmen for joining me today.
Thank you.
Thank you so much, guys, for the invite.
You bet.
Have a good day, guys.
You bet. Bye-bye.